Welcome to Roadmap to Residency's Step 2 Clinical Knowledge Tutoring Series. Today we are focusing on electrolyte disorders, one of the highest yield topics on your boards. We will walk through real exam-style questions together, showing you exactly how to approach these problems and select the correct answer. Remember, if you want personalized tutoring or residency advising, visit roadmap2residency.com. Now, let us dive in. Here are our learning objectives for today. We want you to master systematic approaches to electrolyte questions, recognize the classic vignettes and buzzword patterns, and most importantly, learn test-taking strategies that will help you eliminate wrong answers quickly. For the full content review, be sure to consult your primary board prep resources like First Aid, UWorld explanations, and Amboss articles. We are here to help you apply what you have learned. Before we jump into questions, let us review the electrolyte framework. Step 1. Always identify the abnormality. Is sodium high or low? Is potassium dangerous? Is calcium corrected for albumin? For acid-base, always start with the pH. Step 2. Determine the mechanism. Check urine electrolytes to distinguish renal from extrarenal losses. Think about cellular shifts from insulin or pH changes, and always scan the medication list, because drugs cause many electrolyte problems. Now let us talk buzzwords. These are your keys to quick recognition on test day. For hyponatremia, think post-operative patients on hypertonic fluids, marathon runners who drank too much water, or small cell lung cancer patients with euvolemic hyponatremia pointing to syndrome of inappropriate antidiuretic hormone. For hyperkalemia, look for peaked T waves, renal failure, and the combination of angiotensin-converting enzyme inhibitors with potassium-sparing diuretics. For hypercalcemia, remember stones, bones, groans, and psychiatric overtones. Here is our first case. A 68-year-old woman is found confused on post-operative day 2 after hip replacement. She has been getting dextrose 5% in water at 125 milliliters per hour. Labs show sodium of 124, serum osmolality of 260, and urine osmolality of 450. What should you do first? Take a moment to think about this before we walk through it together. Let us analyze this case step by step. First, the clues. Post-operative setting plus hypertonic fluids is a classic setup for hyponatremia. The confusion tells us this is symptomatic and needs urgent treatment. The low serum osmolality confirms true hypertonic hyponatremia. Second, apply the algorithm. High urine osmolality, greater than 100, means the kidneys are inappropriately concentrating urine. This is the pattern for syndrome of inappropriate antidiuretic hormone. Third, choose the answer. Symptomatic hyponatremia needs hypertonic saline, specifically 3% sodium chloride. Remember to correct slowly, 6 to 8 milliequivalents per day, to avoid osmotic demyelination syndrome. Case 2. An 82-year-old nursing home resident comes in lethargic after 3 days of decreased oral intake. Exam shows dry mucous membranes, poor skin turgor, and blood pressure of 90/60. Sodium is 158 and the blood urea nitrogen to creatinine ratio is 30:1. What treatment do you choose? Let us walk through this hyponatremia case. Step 1. Recognize the pattern. Elderly patient plus decreased intake plus nursing home equals classic dehydration hyponatremia. The elevated blood urea nitrogen to creatinine ratio greater than 20 tells us this is pre-renal azotemia from volume depletion. Step 2. Confirm hypovolemic hyponatremia. The physical exam with dry membranes, poor turgor, and low blood pressure confirms volume depletion. Step 3. Treat appropriately. For hypovolemic hyponatremia, always start with normal saline to stabilize hemodynamics, then switch to half normal saline. Remember, never lower sodium faster than 10 to 12 milliequivalents per day to prevent cerebral edema. Now let us try a practice question. A 25-year-old marathon runner collapses after a race. She drank excessive water during the event. Sodium comes back at 118 milliequivalents per liter. This is severe hyponatremia. The question asks about the biggest risk of overly rapid correction. Think about what happens when you correct sodium too fast in someone whose brain has adapted to low sodium levels. Take a moment to think through this before we reveal the answer. The correct answer is B. Osmotic demyelination syndrome. This is a critical concept for boards. When hyponatremia develops slowly, The brain adapts by pushing out osmolytes to prevent swelling. If you then correct sodium too rapidly, the brain cannot readapt fast enough. Water rushes out of brain cells, and you get demyelination of the pons and other areas. The classic presentation is the locked-in syndrome. Option A, cerebral edema, is actually what happens if you do not treat hyponatremia. Water moves into brain cells and causes swelling. Remember our test-taking tip. Sodium problems equal brain problems. Potassium problems equal heart and electrocardiogram problems. This distinction will help you on multiple board questions. Case 3. A 55-year-old woman with heart failure on furosemide has progressive muscle weakness. Her electrocardiogram shows flattened T waves, prominent U waves, and prolonged QT. Potassium is 2.8. What is your initial intervention? Walking through this hypokalemia case. Step 1. Recognize the electrocardiogram. Classic hypokalemia findings include flattened T waves, U waves appearing after T waves, ST depression, and prolonged QT. Memory trick. Low potassium means low T waves and low muscle energy. Step 2. Identify the cause. Loop diuretics like furosemide cause renal potassium wasting. Always check for diuretics in hypokalemia questions. Step 3. Choose treatment. Symptomatic with electrocardiogram changes means intravenous potassium replacement. Oral is too slow. Key pearl. Always check and replace magnesium because hypomagnesemia prevents successful potassium repletion. Case 4. A 62-year-old diabetic with chronic kidney disease stage 4 presents feeling unwell. He takes lisinopril and recently started ibuprofen for back pain. Potassium is 7.2. Electrocardiogram shows peaked T waves and widened QRS. What is your first step? This hyperkalemia case is an emergency. Step 1. Recognize the danger. Electrocardiogram changes with hyperkalemia are life-threatening. The progression goes peaked T waves, then widened QRS, then sine wave, then ventricular fibrillation and death. Widened QRS means imminent cardiac arrest. Step 2. Know the treatment order. First, give calcium gluconate to stabilize the myocardium. It does not lower potassium, but it protects the heart. Then give insulin with glucose to shift potassium into cells. Then eliminate potassium with kiexolate or dialysis. Step 3. Identify the cause. This is the classic triple whammy: chronic kidney disease plus angiotensin-converting enzyme inhibitor plus non-steroidal anti-inflammatory. Stop the offending agents. Another practice question. A patient with diabetic ketoacidosis has initial potassium of 5.5. After starting insulin, potassium drops to 3.1. Why did this happen? Let us analyze the choices. Choice A, renal potassium wasting, is wrong. While diabetic ketoacidosis causes osmotic diuresis, the rapid drop specifically with insulin is the key clue here. Choice B, cellular shift from insulin, is correct. Insulin drives potassium into cells via the sodium-potassium ATPase pump. In diabetic ketoacidosis, total body potassium is actually depleted, but serum level appears normal or high because acidosis shifts potassium out of cells. Choice C, gastrointestinal losses, is wrong. No vomiting or diarrhea was mentioned. Test-taking tip. Always anticipate hypokalemia after starting diabetic ketoacidosis treatment. Never give insulin if potassium is below 3.3. Case 5. A 52-year-old woman has fatigue, constipation, recurrent kidney stones, bone pain, and depression. Calcium is 12.5, phosphorus is 2.1, and parathyroid hormone is 180. What is the diagnosis? Walking through this hypercalcemia case. Step 1. Remember the mnemonic: stones, bones, groans, and psychiatric overtones. Kidney stones from calcium, bone pain from resorption, groans means constipation, and psychiatric means depression and confusion. Step 2. Interpret the labs. High calcium plus high parathyroid hormone equals primary hyperparathyroidism. If parathyroid hormone was suppressed, think malignancy. Low phosphorus supports parathyroid hormone excess. Step 3. Know the two big causes. In outpatients, primary hyperparathyroidism is number 1, usually from a parathyroid adenoma. In hospitalized patients, malignancy is number 1. Use the clinical setting. Case 6. A 70-year-old man with lung cancer presents confused and lethargic. Calcium is 14.8 and electrocardiogram shows shortened QT. What is your first step in management? Let us evaluate the answer choices for severe hypercalcemia. Choice A, bisphosphonates, is not first. Zoledronic acid is excellent for hypercalcemia of malignancy but takes 2 to 4 days to work. Good for sustained control, not acute emergencies. Choice B, normal saline infusion, is correct. Aggressive saline hydration is always first. Hypercalcemia causes volume depletion through polyuria. Volume expansion enhances renal calcium excretion. Give 2 to 4 liters. The order of treatment is saline first, then calcitonin as a bridge, then bisphosphonates for long-term control. Let us wrap up with the key points to remember for test day. First, sodium problems present with brain symptoms like confusion, seizures, and altered mental status. Potassium problems show up on the electrocardiogram with peaked T waves for hyperkalemia or flattened T waves and U waves for hypokalemia. For calcium, remember stones, bones, groans, and psychiatric overtones. And for acid base, always start with the pH to determine if it is acidosis or alkalosis. Then look at the carbon dioxide and bicarbonate to classify it as respiratory or metabolic. For your continued preparation, make sure to review the nephrology and endocrinology sections in First Aid and complete all electrolyte questions in UWorld. If you found this helpful, please like and subscribe to our channel. And remember, for personalized tutoring or residency application guidance, visit roadmap2residency.com. Best of luck on your boards.